All right, so Dr. Sarkar is on the program. Dr. Sarkar is one of our interventional cardiology faculty, joined us recently. He had a sort of an urgent matter this morning, so he had to get on a plane and fly back to see family. So I'm going to show you just a couple of talks or a couple of cases that we had actually presented for an ASC project creating some DVDs, but really these are just structural interventional cases. So this is a case of PVL after a mitral repair. So here's the story. 43-year-old had a recurrent dyspnea for 3 years. He had bacterial endocarditis 10 years prior, requiring a surgical replacement of his native valve. 3 years ago, he had a thrombotic event with obstruction and then had a redo, again, mechanical valve. No fever, no chills, no weight change, nothing really to suggest an active case of endocarditis now. He was referred for basically assessment of his mitral valve function and discussed the options. So the first echo is here. This is the transesophageal four-chamber. Prosthetic mitral is here. And you can clearly see a paravalvular systolic jet here. If you look on the en face 3D image, there's a suspicion of a defect right here. You know, one of the challenges with 3D is you can turn up the gain or turn down the gain and really create kind of a moth-eaten surface, but we've kind of worked pretty hard to define what's a reasonable gain, and basically you turn it up until the blood pool gets visible, and then you just slowly turn down the gain, and once the blood pool is gone, that's where you stop playing with the gain. And when we do that, that's the image. So we have a suspicion of a defect right here. If that's 12 o'clock, this would be about 11 or so. So I think I just told you that answer, so that's, we don't have to go through all the questions, but this for the DVD thing we were creating for the ASC, there was a series of questions. But basically I pointed where we think the defect is. I can scoot through this stuff. So this is the sort of the typical clock face orientation. One of the ways that we help figure this out, we can be suspicious on just the 3D imaging, but we add in the color. The frame rate is very low. This is one of the limitations of 3D echo. It's only 2 hertz, but it doesn't matter. We just need to see one shot of systole to know where the paravalvular jet is coming from, and it's right there where we suspected. We can turn that data set kind of sideways. You don't have to have that 12-6 orientation, but as long as you know where 12 o'clock is. So we were just confirming that there's really one single defect. This is important to note here, although this is sort of flashing, if I can stop it right there, yeah. Note when you see paravalvular defects, not paravalvular, sorry, when you see washing jets occur at the hinge points. Remember, this valve was oriented like this. So these little jets don't occur randomly anywhere around the prosthetic valve. Washing jets occur where the hinge point is. So if you know where the hinge point is and you're wondering, is this a paravalvular defect or is it a washing jet? Identify the hinge points, and these little dots we don't worry about. That's not a hinge point, and it's outside the soul ring, so it's paravalvular. Okay, and that was just sort of a zoomed view just to get a rough size of the size of the defect here. So it was 3 millimeters by 10 millimeters for the paravalvular defect. So we sort of, I've taken you through those answers. This was the repair. So a transeptal puncture, catheter. Colin and I have done these for quite a while now, and I must say, they were always a bit of a challenge. They were effectively impossible before 3D echo, but having had a mitral clip experience, these are kind of a slam dunk now. That whole idea of really picking your transeptal puncture location to allow you to get the catheter in the right place and the communication. So these are much, much easier, having done at the time a couple of dozen mitral clips. Anyway, so transeptal wire and catheter across the defect. So here we have the device in, and we still see some PVL. So now we're like, this is concerning. We think we fixed it, yet there's too much PVL. So right away we start the conversation. Well, do we need another plug? Is the plug undersized? What's wrong with the plug? And go through these questions. I can just ask you these sort of. One of the things I'll point out, that this particular procedure was uncertainty whether we would need 2 plugs or 1. So it was double wired, right? 2 wires through the hole in case you have to put a second plug. It's much harder to get the second wire through if you already have the first plug. So double wire, 1 plug in. There it is. There's the catheter still. The first plug has been put in. Here's the valve beating away. But when we look closely at this plug, it looks kind of like the edge is lifted up. And in fact, what was happening, if we zoom in, on 3D is you can see that the second wire had actually lifted up the edge of the plug. So the plug was not lying down flat against the surface. And we just communicated this real time and during the procedure said, this plug doesn't look right. I think the wire is affecting the plug. Colin just kind of wiggled the catheter. The wire slid around the upper surface of the plug that was there. The plug just lay down flat, and that was it. So the plug was just simply not fully deployed because of the second wire. It lay down flat now, and the paravalvular leak was basically gone. So instead of putting a second plug and all these things, the teach point there for us was simply, make sure the device has done what you think it did and that it lay down properly in the way you intended, and it wasn't being impacted by the wires that you had, the contingency wires for a second procedure. Any comments on this one, Colin?
No, I mean, I think that was the, because I hadn't heard of anyone describing that before with the wire actually, because those are pretty, this is an 018 Platinum Plus, so you wouldn't think it would have had that much distortion, but just wiggling it a little bit fixed the problem.
I didn't move fast enough to grab the wiggle move, but the wiggle move was I saw it move, the wire slid around the top of the device, it just lay down flat, and that was the end of the case. Okay, so that's that one. Any comments on that one? All right.
Yeah, the comment is from a surgical standpoint, it's great that you guys can do this now, because if we operate on somebody for something like that, it's a really big deal for it's a long run for a very short slide.
Yeah. All right, so this was another mitral clip. I think was instructional for us to go through this one. So 89-year-old dyspnea at rest, a prior history of coronary disease, a CAB 20 years prior, prolapse followed by his local cardiologist for many years, lived alone, fully independent until about 3 months ago, and he and his daughter came to clinic and said, he's had a clear functional decline. Now he had to move in with his daughter, but otherwise had been doing very well. So this was his TEE, and the first shot didn't look too bad. You're going through the 4-chamber view and a 2-chamber view, and pathology is not obvious. But when you go a little further, and you sort of bring out the most lateral aspect of his valve here, you see that there's actually a very large flail segment. Very large flow convergence, and the jet itself was a bit underwhelming because it was completely perpendicular to the angle of the ultrasound. So, as a velocity map is tough to get accurate if your axis, if we heard about over the last couple of days, if cosine is 90 degrees, you're going to underestimate. So the color flow within the atria wasn't impressive, but the proximal stuff was. You really didn't need the color. There was a massive flail. You could see a big hole. Left upper pulmonary veins confirm, systolic flow reversal. So without question, this gentleman had severe MR. So the issue is, when you look at the 2D images, it can be tough to figure out what's a P2, what's a P3. It's easy usually to say, this is anterior leaflet, this is posterior leaflet, but P2 versus P3 can be kind of subtle. And you can, depending on how you do your 2D slice through that lateral element, you might or might not get it right. But with 3D, it's very easy. You just want to put the 3D image on and you look down. So again, we orient with the aortic valve at 12. So P1 moving lateral to medial, 1, 2, 3. And you see here, it's a little sort of moth-eaten again. So some patients' images look a little different, but clearly the problem is P3. Here's a still frame showing P3, flail. And even this one, the bottom right here, is rotated around and the arrow actually shows the visible hole. You're sort of looking right down the gun barrel of the big defect. So that's a large P3. So these aren't the slam dunks that we've heard from MitraClip. Initially it was always A2, P2, straight down the middle at 12 o'clock. So these get a little harder when you start moving medial. It's a little more challenging in terms of how you orient the transseptal puncture to get the catheter in the right orientation to get that. So here is the first attempt. So we've sort of got the catheter across. We're obviously not aligned up A2, P2. You sort of go, as Dr. Q is fond of saying, Sutton's Law, you go where the money is. So you see what's the full quote word? Sutton was asked, why does he rob banks? And because that's where the money is. That's where the money is, right. So P3 is where the money is. So you've got to grab P3. And what we've done before, of course, we showed this in the live case, you orient, and then after you cross the valve, the little trick is to make sure you're still in the same orientation, you just turn down the gain. That makes the leaflets disappear, but because the device is so bright, you still see the device. So that's taking advantage of the fact that you can make leaflets disappear by playing with the gain. So then you know you're still in the right orientation, even though the device is now in the ventricle and below the leaflets. So here's the actual grasp. So we get this is probably still A2, but now we're angled a little bit to get P3. And this is all confirmed on the 3D views. Colin has sort of pulled back to get good traction. Okay, so after deployment of a single mitral clip across the A2 P3 region, the mean diastolic gradient was 2, and the residual MR is significant. And then this question is about, well, what do you do next? So this is the deployment. Initially looks okay. In this Commisuro view, you still see the prolapse and a little bit of color on both sides, but when you change the angle a little bit, you still see we've got still a very large residual. So this one's really not one for debate, and not like the live case the other day. This is clearly a significant residual MR. Okay, so the next step should be what? So really, I just go to the answer. We had to set it. We really want to deploy a second clip. So here we are, clip 1. We still see P3 flail, and really this was just a choice of getting a second clip even more medial than the first clip, and really trying to find that sort of smooth spot. And you have to go through the motions of figuring out, is the regurgitation really medial or lateral to clip number 1, and in this case it was pretty clear. And so this is clip 1, showed down here, sort of, this is the atrial view again. Clip 1 is grabbed this portion, and we're trying to get clip 2 more medial to get this residual prolapse. And I think typically in this case, Colin will close the clip somewhat so you're not crossing with its full opening. You sort of make it look like an arrowhead a little bit to get into that smaller orifice. This is the grasping. Then this is the residual. So second clip closed. Now finally, here's clip 1 and clip 2, and these 3 very small little jets. And then this is the final. So the tissue bridge, we've got 2 clips with a very medial tissue bridge, and effectively only 1 big diastolic orifice. So you've got a lateral orifice, and that's it. You really don't have any discernible orifice at all with these tiny little pinholes medially. There's a still shot, but the mean gradient is 1. So even though we added a clip, the gradient actually went down because we took away the regurgitant flow that was driving the gradient. So any questions on that case? That was just sort of an atypical mitral clip. Okay.
So that's not clipping 101, right?
That's not clipping 101. No, that's there was a sweat factor there. I didn't put on the duration of that case, but it was a little longer. And the last thing I want to show you is.
But Steve,
Yeah.
can you go back again?
Yep.
How did you know that the second clip was better to go further medium?
Okay. So that would be.
What was your, because that was the key decision there was where to place a second.
So this, I don't know, this, I didn't put a video for some reason, but this was post clip 1. Clip 1 is here, and on a moving video, we could still clearly see P3 that was medial to the first clip.
Okay.
So in this case, it was
Yeah, a segment flailing.
a big flail segment. You got it. So effectively, the first clip was close, but it missed. We went what we thought was on the clip, but by the time you closed everything, we didn't grab it. We got non-flailing leaflet. And sometimes that's what you have to do, is the first clip facilitates the second clip, because it brings everything a little closer, so then you can get the flail on the second attempt. So this case was easy. We didn't have to go to color to figure it out. There was.
You couldn't tell that before you release that clip, I guess. Seemed like you would do that, put it partially, and then look, see it's not right, and then undo it. And move it over.
Well, what you have often is you have a significant reduction of the MR. So you see a reduction because everything's a little closer, and you think, well, we've achieved something. And I didn't.
Then it might get better when you release the clip, I guess, like that case yesterday.
Well, sometimes you just say, look, we're going to need a second clip anyway. We know we need a second clip. So as long as the gradients are prohibitive, if you put on clip 1 and you have an improvement MR and your gradient's only 2, then you know you've got the option for a second clip. If clip 1 has a gradient of 6, that's when you have some sweat factor, because you don't know if clip 2 is going to go to 9 because you've made the orifice so small, or if clip 2 is going to go to 4 because you've taken away the residual MR. And that's the challenge, is when the first clip mean gradient is about 6. That's the one it's much harder to decide what to do. But when the gradient's so low, you can almost put a second clip with impunity. Okay. So I'll just show you the last one here. Let's see, get rid of this guy. And this is just kind of a couple of fun cases because we have a little time, and I think Dr. Ramchandani is going to close this out for us. So this is a gentleman, I showed this in Grand Rounds a couple of days ago, but a lot of you weren't there, so I'll show it to you again. So quite a sick guy, 71 years old, presents to clinic with class 2 heart failure. So his history was very complicated. He'd had an aortic dissection, complicated perioperatively by endocarditis, bioprosthetic mitral valve, bioprosthetic aortic valve, effectively rebuilding his cardiac crux because he had such extensive endocarditis. Post-op, complicated by hemorrhagic stroke and AFib, and a very long, sort of hospital course healing from all of this. So then he comes back really a couple of years later now, and only a couple of years later, and this is his echo. So he has clearly a large ASD, and effectively this is an iatrogenic ASD. So we dug out the operative note, and the operation was a transeptal approach to the mitral valve replacement in a setting of endocarditis and all kinds of things. So it's a very unusual ASD. It's very low, and it's down by the mitral valve. Yeah, it effectively is a primum ASD, post AVR, MVR. On the color flow, you can see he's got a little bit of flow acceleration across the prosthetic mitral valve, but he's got a ton of flow across this ASD straight into the tricuspid valve. He also had some RV dilatation, some RV dysfunction. It was interesting, one of the early steps we did was a cardiac MRI to try to figure out the shunt. Actually, before the TE, we did an MRI, and the shunt calculation was very mild. It was like 1.4 to 1, which was, just couldn't believe that, and we did the TE anyway. And I think the MRI was challenged by the atrial fibrillation and all of the artifact by the 2 prosthetic valves. So in retrospect, that was wrong. But this was the one scenario where the TE, I think, was more valuable than the cardiac MRI. This is the 3D TE. This is the same orientation I've been showing you. The aortic valve would be here. We're looking down on the mitral valve. And here's the ASD, very low, and really quite close to the mitral. So we were considering a percutaneous closure of this ASD, but it's very low, and the concern would be interfering with the mitral valve function by putting a closure device on there.
So to take a lesson from the schizophrenia, how much of a rim do you have?
So it depends. So above, infinite. Below, there's no septum below. It's basically the floor of the atria. Pardon?
You could use an ASD device. You have to use something that's more plug-on than an ASD device.
So again, this is a nice follow-up for these conversations about valve team. So this case was discussed at our multidisciplinary valve conference, and we sort of showed not this particular view, but these are the challenges. Would a plug device work? Would an ASD occluder work? We didn't know what to do.
Also note that being surgeons, that valve rim actually sits up away from the mitral wall.
Yeah.
And then if it hits that, it's not going to be flat.
All right, so this is exactly the conversation we had. We wanted to plug it.
Very important consideration, because that means
You can't lay.
none of the current
So,
Even if it's going to lay on that valve, it's not going to contact the wall.
right.
It's less of an issue of interfering with the valve, because you're looking at the inflow part of the valve, it's not going to be flat against the wall, it's just a plug line thing. I'm not worried about why so let the atrial pressure so high that we're shutting this.
Yeah, and so that's an issue. And there's also 2 very small little pinhole defects, little paravalvular leaks on this as well. So there's 2 little holes, which we see after endocarditis. There's a big hole, and there's a little bit of extra gradient here. Now, the actual measured gradient across the valve was only 4. So we're not actually measuring. We see flow acceleration in color. It's hard to reconcile. In fact, one of the concerns is the ASD causing us to underestimate what the mitral flow gradient would be? We plug the ASD, now the mitral gradient might really be dysfunctional and pop up to 9. We don't know. But this is sort of the planning for a tough case. So what we did, and what we've been doing for a while now, is we did a CT and we 3D printed this anatomy. So we could actually look at a bunch of different devices and try to understand how would they interact with this prosthesis. So we took a CT, topic for another day, is we've, at our center, have done a lot of 3D printing for these complex cases. We picked some materials, we replicated not the entire mitral valve prosthesis, but at least the so ring, so we know what our limits are. Here's the defect. And the question was, could we put an ASD device through it? So in this case, it was a Gore helical device because it was flexible enough that it would actually fold into that little curve, and it wouldn't be rigid. And this was Huey and Colin and I, we sort of discussed this and got together and tried to figure this out. Then we took that 3D printed model and we went up to the hybrid suite, and we did a rotational. Oh, sorry, I went a bit quick. No, we just had apparently we had a cloak of invisibility. I don't know, I'm not sure. It worked a moment ago. It doesn't like the projector. I'll describe for you this video. It's a little plastic model with a rotational thing spinning around it. That's all we did. But having done that, let's see, we got this view. So this is now a CT of the model with the device. And the reason we did this was to see the frame of the device and its conformation and how it would really impact. And really what you wanted was this device, in theory, to just touch the surgical ring to give it extra support. So it really can't push through despite the LA pressure. And it's interesting that the CT really revealed even these little pinhole paravalvular defects. So the CT, the first clinical CT was so good that it saw the holes, and then when we 3D printed the model and then CT'd the model, the holes were still clearly evident. And in fact, when we take this and line it up with the jets I didn't show you on the echo, that's exactly where the small paravalvular defect is. So this is a view of the device from the atrial side. This is a view of the device from the left atrial side and then the right atrial side. And then Panraj, who's one of the technologists, he works with Siemens, but he's sort of an integral team member for us in terms of doing this sort of image manipulation. This is simultaneous, unrepaired model on the left, and a model of repair on the right, looking from the RA and sort of slicing through. And you can even see, if you look over here, that you see the struts of the prosthetic aortic valves kind of tucked up in here. And you see where it sort of flattens out. And with enough tension, you pull it in, and the device just sits there like a little cup. So this is basically sort of team procedural planning for effectively an inoperable case. And here's the tricuspid valve rim down here, the beginning of the septal leaflet. We didn't print the whole valve. We just wanted to know where the septal leaflet was to make sure that the RA side of the device wasn't going to impact the tricuspid valve function. So that's as far as this case is. This was done last Wednesday. We're now scheduling the patient. Some of the challenges going forward, and I don't know if this is going to end up as a good, bad, or ugly. Part of the challenge here is that the mitral gradient, the LA pressure appears higher than what we're measuring. What will happen to the diastolic flow across the mitral valve once you plug this hole? We may need to ultimately do something else to the mitral valve. That's kind of where we are. So stay tuned for a clinical update. And the last one I'll show you is probably more satisfying because we actually have a final result. Similar concept, this is only a couple slides. This was a case, a different young man, he's in his 50s, end-stage renal, peripheral vascular disease, very sick, refractory heart failure, and came to us from the Valley, was in hospital for several weeks on inotropes, and what he'd had was more recent endocarditis, now culture negative. He had a perforation in his posterior mitral leaflet, as well as central MR, so he had both. Also some wigglers still on the ventricular surface of his mitral apparatus. About a year prior to this, we had done a procedure where we actually put a plug through the posterior leaflet of a different patient, and we thought, well, we might do that again. This guy's even more complicated. So this is the 3D. He's got a central coaptation defect of his mitral valve. He's got a perforation through his leaflet. In a similar way, we did a 3D printed model. Here's the CT. Here's the echo that shows the perforation. We did this is the computer recreation of his mitral valve. Then we printed that to identify this defect. So we actually recreated the hole in his leaflet, met with some device reps and tried to come up with the best device that might actually go right through his leaflet and plug this hole. And we ended up with this choice of device. And this is sort of the 3D print of his left ventricle, left atrium, and outflow tract. This is looking down on his mitral valve. You see this sort of curved, it's kind of semi-lunar perforation. All this yellow is the calcification that is specific to him, that's actually on the undersurface of his leaflet. We picked an ADO device and we sort of sized it based on this modeling. We implanted the device in the model and saw that it laid out very well, both from the atrial side, but more importantly on the ventricular surface where all the calcium was, this device laid down flat. And I showed you the other case where when the device doesn't lay down flat, you don't plug the hole. So it did lay down flat. We thought, well, this is the best chance we have. The procedure was performed. We started with a mitral clip first, transeptal puncture, perforation through the posterior leaflet, and you sort of get this, this final result with a plug and a clip. And an immediate reduction of MR, and finally he went from sort of 5+ MR to mild MR. And this is my last slide. The blinking dog, which should look reminiscent of this guy. So there. This case falls under, this is the good. Hopefully the other one doesn't become ugly. All right, I'll stop there. Any questions on any of these cases? Yes? Dr. Barker, do you recall?
We just used, so what we do is we actually use the mitral clip delivery sheath to target it, and with 3D echo it was just a 035 straight wire, like we cross a stenosed aortic valve. And then just put a you know, like a multi-purpose catheter, a 4 French multi-purpose catheter through the hole, because those ADO2s can go through a 4 French system.
With that device? Well, the nice thing is, so, you know, mid P2, there's not a lot of cords there. You know, the closer you get to the commissures, the more chordal concentration you have to deal with. So there are almost, you know, there might be one cord in mid P2. The cords are commissures and all along the leaflet edge. So the more you do in the commissures, the more you're worried about cords. So that's a big deal when you do mitral clip. You get down there and you're off center, and then you figure, well, I want to rotate a bit. Well, the concern is you're in a nest of cords trying to rotate or slide medial and lateral. That's a problem. But mid-posterior leaflet, there's not really any cords that I worry about. Yeah, good question. All right, I will bow out, and we'll get Dr. Ramchandani up here. There he is.